Hi everyone, and welcome to the World Epilepsy Day brought to you by Sanofi. In today's episode, we'll be discussing epilepsy, how it's diagnosed, the different types, the available treatment options, and how physicians can help their patients manage their diagnosis better. I'm Yasmin Mitwalli, and today I'd like to welcome our guest, Dr. Tawfiq Sadi, Chief Medical Officer and Chair of the Neurology Department at the American Center of Psychiatry and Neurology in the UAE. Dr. Sadi is also Adjunct Professor of Neurology at Khalifa University and is currently the president of the Emirati League Against Epilepsy. Dr. Sadi, thank you for joining us today.
Thank you for having me.
So let's start with our first question. Dr. Sadi, can you give us an overview of what is epilepsy?
Well, epilepsy is a brain disorder characterized by recurrent and unprovoked seizures. It's estimated that around 50 million people worldwide have epilepsy. At any given point of time, about 4 to 10 patients would have active epilepsy that would require treatment.
What are the different etiologies of epilepsy?
Well, according to the International League Against Epilepsy, they tried to come up with the list of etiologies that could account for patients' no onset epilepsies. Basically, we can look into structural causes, genetic, immune-mediated, infectious, as well as metabolic causes. These are the main etiologies behind new onset epilepsies. For instance, if you look at structural causes of epilepsy, you know that hippocampal sclerosis is the main culprit of underlying temporal lobe epilepsy. And this is an example of what we call structural causes of epilepsy. Any insult to the brain cortex would put these patients at risk of developing epilepsy, especially if the insults involve the cortex as well as certain parts of the brain, especially the temporal lobe. I'll give you an example. In cases of brain tumors, especially those that involve the cortical areas, especially if it's of a significant size, that would be an example of etiologies related to, for instance, structural causes of epilepsy. In addition, we have other structural causes of epilepsy, including those related to vascular malformation, cortical malformations, as well as insults related to brain tumors and brain traumas, for instance. These are some other examples of structural causes of epilepsy.
Can you shed some light on how epilepsy is diagnosed?
Well, the diagnosis of epilepsy is straightforward. It depends on history. History is the main area where we invest the most in order to get the diagnosis. Obviously, the history should be taken by the patient as well as by people who had witnessed patients having events of loss of consciousness. But I must admit, obtaining that history is not that easy because we rely on witnesses who may or may not have any medical background, and we try to tease out the information that is required to understand if these events of loss of consciousness were epileptic in nature or not. But history is the first start to make the appropriate and accurate diagnosis. This will be followed by what we call EEG. EEG can be obviously important to making and confirming the diagnosis of epilepsy, but we have to keep in mind that the EEG can be normal in at least 50% of the time after the patient having their first witnessed unprovoked seizure. And what we do, we try to ask for either serial EEGs or prolonged EEG, especially those following sleep deprivation. So the longer the EEG, the better the yield would be in order to making that diagnosis. In cases where we suspect that the etiologies of epilepsy are secondary to other etiologies, for instance, structural cause of epilepsy, we're suspecting other etiologies of epilepsy, then that's where the CT of the head and preferably MRI, especially what we call MRI with a special protocol of epilepsy, would be quite important to confirming the diagnosis of epilepsy and looking for secondary causes of epilepsy. Obviously, there are other tests we can also do to further confirm the diagnosis, but mostly I would emphasize that the diagnosis is made by history. History is the most important element that we will start off with in order to making the diagnosis of epilepsy.
That's very interesting, doctor. When it comes to management, what are the latest management and treatment options that patients with epilepsy have?
In order to have a good response to treatment, we need to understand what are the underlying epilepsy syndrome. The best approach to management is first to understand what could be the cause of epilepsy. In generally speaking, when we have a patient with epilepsy, we try to divide them into two categories. One is called focal and one is called generalized. And there is another category which is called unclassified, meaning that we don't know based on the testing we do that we are dealing with focal epilepsy, generalized epilepsy. For patients who have focal epilepsy, obviously the main treatment options will be rely on medications. And the medications can be an option and can result in successful treatment in terms of seizure cessations and no side effects in about 60 to 70% of the time. The problem relies on patients that may not respond your first or second line anti-seizure medication or combining various anti-seizure medication. For those patients, what we refer to as having intractable or difficult to control seizures, for those patients, we have to look for other options of treatment, such as, for instance, epilepsy surgery, vagal nerve stimulator, other methods where we can try to control the seizure, including obviously diet can be also an option in patients who may not respond to treatment or medications alone. Now, in the case of generalized epilepsy, the prognosis is much better, where about 80-90% of patients would respond to treatment, provided that we choose the right medication. And this is a key in making the appropriate diagnosis in patients with epilepsy. Because if you miss the diagnosis of patient with epilepsy, patients may not respond to treatment. And that's an example where we see in patients with generalized epilepsy. If you have the right diagnosis, you use the right medication, 80-90% of the time, patients would respond to treatment. There is about 10% of patients that will require other methods of treatment in order to get the best response.
Based on your on the valuable information you just shared, it seems like it's very important for to find the right treatment, to be able to diagnose the patient and find the right treatment and how that plays a role in the patient's journey. What happens when a patient is left untreated? What are the consequences on the patient?
Well, the problem with epilepsy that it can affect patients at multiple domains. Firstly, obviously, I don't want to frighten the audience, but once the diagnosis of epilepsy is made, your life expectancy is reduced by, on average, 7 years. In addition, there's an entity called sudden unexpected death of epilepsy, which is referred as SUDEP. And it turns out that the rates of SUDEP, or sudden unexpected death of epilepsy, is far more common in patients with active epilepsy, those who have uncontrolled epilepsy, as compared to patients who have well-controlled epilepsy. In addition, what we know so far, that patients with epilepsy are at far much higher risk of having all kinds of injuries, burns, injuries related to different parts of the body as compared to the general population. It also can affect the patients at other domains, including their social life, marriage life, friendship, and more importantly, their work. We know that the rates of unemployment is far more higher in patients with epilepsy as compared to the general population. So certainly, if your epilepsy is not treated, that could have a negative impact on multiple domains and unfortunately would result in worsening quality of life in those patients as compared to the general population. One area that we always have to emphasize on is that once you're diagnosed with epilepsy, especially if your epilepsy become uncontrolled, that could affect your driving privilege. So you're not going to be able to drive your car, you're not going to be able to live your normal life if you have epilepsy, especially for those who do not have well-controlled epilepsy.
We know that you've done a lot of research yourself in the region, and we'd really be interested if you could shed some light from your findings on the burden and the epidemiology of epilepsy in the Middle East.
Well, the data on the effect of epilepsy in the Middle East region, generally speaking, is quite limited. I can share with you some of the data that we had published in UAE, where we have looked very carefully on very important aspects in patients with epilepsy. We know that patients with epilepsy, generally speaking, they are at high risk of having psychiatric comorbidities. Depression, anxiety, psychosis are far more common in patients with epilepsy as compared to the general population. So what we did in our studies in UAE, we've tried to compare the rates of depression and or anxiety among our patients with epilepsy as compared to age-sex match controls. And what we've learned from these studies, that the rates of depression and or anxiety in our patients is far more common than our general population. In addition, what we have learned that the rates of depression and the significance of depression is far more important in terms of the overall negative impact on the quality of life as compared to the seizure frequency. So the rates of depression is an independent predictor of these patients' quality of life, not so much related to the seizure frequency, but the rates of depression is by itself is an independent predictor of the overall quality of life. In another study, we've also compared the rates of depression and anxiety as compared to other chronic neurological disease states. We took as an example patients with multiple sclerosis. We came up to the same conclusion that patients with epilepsy are far more common to have comorbid psychiatric disorders, namely depression and or anxiety, as compared to patients with multiple sclerosis. Similarly, we have seen that the quality of life in these patients is much more worse as compared to their comparators. I must say here that the quality of life in patients with epilepsy is negatively impacted by multiple factors. Obviously, having psychiatric comorbidities, the frequency and intractability of the seizures, the number and the type of medication these patients are taking, all these factors would negatively affect the quality of life in patients with epilepsy. And that's what we have learned from our studies. And I'm also aware of other studies in other parts of the region that have also showed higher rates of unemployment in patients with epilepsy as compared to the general populations. There are other studies as well have looked at the effect of epilepsy on their social stigma, for instance. And we know that patients with epilepsy, unfortunately, because of the stigma, they're quite affected by that, despite we are in the 21st century, but still we have a stigma towards epilepsy and how we can review and look at patients with epilepsy.
Yeah, it's definitely sad to see that it's still like that at this time and age. But also, it's really great to see such valuable research and data coming out from the region in that particular field. So, based on your experience from your current practice, from your research, can you share some recommendations on how to improve the quality of life of patients with epilepsy in the region?
Well, very importantly, we need to make sure that we identify a patient with epilepsy. We make the appropriate diagnosis, confirming the diagnosis and offering these patients the best treatment modality that we do have. Once patients' seizures are well controlled, these patients are more likely to carry on their life normally like any other person in the society. And that's going to be the goal of treatment, to control the seizures with no side effects and overall improving the quality of life with these patients so they can carry on with their life without any obstacles. And that's going to be the main goal of what we do in the field of epilepsy. It's very important for patients with epilepsy that we need to educate the public about what is epilepsy. We need to increase the awareness about epilepsy. We need to make sure that people understand that patients with epilepsy can and should live normal life, and they should be an active members of the society, contributing to the growth of the society like any other person as well. But in addition to that, we need to educate, more importantly, not only the public, but the primary care physicians, the family care physicians as well, about all different types of epilepsies, when to make the appropriate referral to the specialized services in order to have these patients cared for in a better way and get their seizures well and better controlled.
Thank you, Dr. Sadi. This has been very interesting, and hopefully what we're doing here is like one step forward, and definitely with all your research that you're doing, contributing to this general awareness and contributing to the field. We've reached the end of our podcast. Thank you for tuning into the World Epilepsy Day podcast. We'd like to extend our gratitude to Dr. Sadi for joining us today and sharing with us his expertise and valuable knowledge. Dr. Sadi, thank you for joining us and thank you for your time.
Thank you for having me.
Thank you.